Now can I request Dr. Atul Varma? He will speak on posterior uveitis, a case-based approach for diagnosis and management from a UK hospital uveitis service.
Good morning, everyone, and thank you AIOS for giving me the opportunity. So I'm just going to share what we do in the uveitis clinic. I don't have any financial disclosure related to this talk. As we know, posterior uveitis is inflammation of the choroid and the retina. It could be infectious and non-infectious, and that's a really important point, which Dr. Singh also reiterated. But it can lead to significant visual loss. The incidence in the UK is around 1.25 patients per 10,000. And it's normally a disease of the working age group. So that's why it's really important to catch these patients early and treat them. They present most commonly with blurred vision, floaters, and the most common signs are either choroidal infiltrate or vitreous cells. But one of the main things always to do is, beside examination, is take a detailed history, because a lot of time you will get the diagnosis from the history itself. You don't even have to go for any examinations. And then if you have to do examination, a multimodal examination is important. As we know, these are the common causes of infectious and non-infectious uveitis. I think some of them already been discussed. The main thing is, when we are seeing any patient with uveitis, what are our goals? First, it is reduce inflammation, treat the underlying cause, and then preserve vision. And the medication which we use are corticosteroids in various forms, immunosuppressants, and anti-infective agents. But there are other treatments also there, which are like intravitreal injection, Ozurdex, or any intravitreal steroids, or any antivirals, laser therapy, and vitrectomy sometimes. So whenever you see a patient of posterior uveitis, the most important thing is to rule out infection. This is really the most. If you delay the treatment in an inflammatory uveitis by a day or even a week, it will not have that major detriment effect. But if you treat with steroid in a patient with infective uveitis, you will cause a disaster for this patient. So that's one of the most important things. And treatment depends on whether one eye or both eyes are involved. If both eyes are involved, then normally oral medications are better. If one eye is involved, you can give local injections or Ozurdex or something. So let's go with the cases. This 26-year-old Caucasian female presented to us with floaters and flashes. Optician had seen the patient and referred for epiretinal membrane and bilateral blurred optic disc margin. Visual acuity was 6.6, but there was 1+ inflammation on the vitreous with slight blurring of disc margin. And because of that, we also requested for MRI brain, but there was no other positive medical history. So these are the optos pictures, as you can see. I don't know whether it's visible, but you can see some lesions which are radiating from the optic disc in the right eye and also in the left eye. And then these are the OCT maculas at baseline, and I don't know whether you can see some of the inflammation in the vitreous in the OCT. That's the OCT of the optic disc in the right eye, which shows some like disc swelling in the left eye. So what are the differential diagnoses? It could be birdshot, which because of the lesion which are radiating from the optic disc, multifocal choroiditis, panuveitis, mutes, MP, sarcoid, syphilis, tuberculosis is a differential diagnosis in every posterior uveitis case and primary CNS lymphoma. So we got all the investigation, all the immunological markers, viral syphilis test, and HLA-A29, all came back negative except the HLA-A29, which was positive. But we need to remember that 9 to 10% of the patients in a normal population also have HLA-A29 positive. And we had also requested for an MRI with a venogram with that. So we requested an FFA. So that's the fundus image on the 25th January 24 on the left eye. And then there's a multicolor picture from the Heidelberg. And then as you see the FFA, there's a vasculitis, but it's involving both arteries and the vein. And that's the left eye, similar picture. So we started the patient on oral steroid. And that's the other thing which is really important. If you have to start steroid, start on the high dose. Don't start on homeopathic doses like 50 milligram, 20 milligram. That will do more harm than benefit. So always start on 75, 60 milligram, like 1 to 1.5 milligram per kg body weight, and then reduce it down slowly. But because this was looked like birdshot, so we referred her for the immunosuppression also to the immunosuppression clinic, because when you start tapering the steroid and when we came down to 10 milligram, they used to have a flare up. And that's the later on picture for OC. Second picture, second patient, a 32-year-old female, presented with floaters in both eyes, and then saying that it's just like a static on the TV where she gets a bit of glare with some anterior uveitis. And so we requested. But when on further questioning in the history, she did give a history of recurrent mouth ulcers and genital ulcers. So that's the early phase FFA, and you can see retinal vasculitis both in both the eyes, which increases. So as the history was suggestive of Behçet's, so we started the patient on oral steroids. But then these patients would not just be on oral steroids, so they will need immunosuppression also. So as soon as we started to taper, as you can see, the disease is still not under control. So even with oral steroid, the disease is not under control. You can still see a lot of inflammation, and that's an optos fluorescein angiogram. And then so we referred her, and then we started on azathioprine also. And as you increase the dose of therapy, you reduce the dose of steroid so that you come to for long-term immunosuppression. But in between, she had a flare-up, so then we gave her a pulse steroid 500 milligrams for 5 days also to help us to control the disease. And this is the most recent FFA. As you can say, still the disease is better, but still not fully under control. So that's why they might have to go on to biologicals or anything. Another patient, 42-year Asian male, presented with blurred vision, previously had some eye problem. These are the optos picture. You can see a scar with some active lesion just below it, and which is very well documented on the autofluorescence picture. Left eye is fine. And then basically if we do a fluorescein, that lower area stains quite heavily. So this is active toxoplasmosis. Started on just like Septin type of tablets, and after a few days started on steroids also. We continued for 4 weeks, and patient responded. But as you know, the reason for posterior uveitis, and it can be a cause, so that's why you should always rule those out. And these are the only indications where we should treat ocular toxoplasmosis. If the macula is being threatened, if the disc is being threatened, any major blood vessels is being threatened, or pregnancy, monocular state, immunocompromised state, or anything. And that's where you can give any of the medication.
Please wind up fast, Dr. Varma.
Okay.
We are time off.
So I will leave this picture. So this is a patient of 67-year-old Caucasian male who presented with sore, painful red eye, who had a lot of synechial rubeosis. We did all the tests. He did not give any positive history also. So optos pictures did not show. There's a lot of inflammation in the retina. And so ARN and all of that were done. So we did a TAP and gave an intravitreal phoscarnet at the same time at the TAP. But we sent for PCR, but his syphilis triple paradigm came back positive. And then we refer to the GM disease also. And they all need MRI of the brain because they do have CNS syphilis also. And I've got a number of other cases, but I'll just skip some of those. So this patient is, again, like tubercular uveitis, where you can develop peripheral NVE with a lot of retinal ischemia. And this is just one more patient which I wanted to discuss. This patient presented with a patient of temporal arteritis, a 78-year-old female with these lesions, and then you can see obliterative vasculitis. So these patients are where you need to do an urgent TAB. So we did an urgent vitreous TAB within an hour, gave her intravitreal phoscarnet, sent for PCR, came back positive for VZV, started on valacyclovir.
You can go to your last slide, please.
So my take-home message is rule out infection, even if it means delaying the steroid or immunosuppression. Don't be afraid of doing a vitreous or aqueous TAB, because that will give you the diagnosis. And especially if you consider infections, it's always urgent to do a vitreous TAB or an aqueous TAB and give phoscarnet or oral antiviral. It will not do any harm to the patient in the short term, but if it's a viral pathology, it will really save their vision. And take a detailed history. And don't assume things because of age or race. Syphilis and tuberculosis can present. Even syphilis I've seen in patients of 75, 80-year-old patients also. And then always beware of red flags, which are first episode of uveitis in elderly patients, significant systemic illness, immunocompromised patient, and high-risk behavior, and hospitalized patients. Thank you.
Thank you. Thank you. How common is syphilitic uveitis in your clinical practice?
It's on the increase, I think, worldwide. The syphilitic uveitis
Yes.
is on
In
the increase worldwide.
India
so that's
also
why,
we
and
are
it's,
seeing
it's,
more,
it's one of the greatest masqueraders. So you should always test. So any patient with posterior uveitis, we test all of them for syphilis. The only problem is for sometimes with HIV, you can't test for HIV without their consent. So if they don't give consent, then you can get a CD4 count. That will give you the diagnosis sometimes.
Okay.
So suppose we are planning for surgery, cataract surgery in toxo case, is there any role for prophylactic treatment?
No, there's no
Is there
role.
any chance of flaring up of uveitis?
No, there's no chance of flaring up. And I said even if there's a flare up of uveitis, there are only those specific indications where that a disc, macula, or a major blood vessel is threatened, or it's only eye, then only you give treatment. Otherwise, even if you don't give treatment, they will resolve in 4 to 6 weeks' time. Most of these patients.
Thank you, sir.
Okay.